In this episode, we are talking about the Impact and Investment Fund. So, this is part of the PCN DES contract, and there have been some significant changes announced in terms of how that's going to impact the care that we offer to patients in this financial year and directions for what is happening in the next financial year as well. So, myself and Andy are going to cover that entire document for you. This is going to be detailed and it's going to be hopefully really helpful to all of you as we try and take enhance your primary care and learning. Let's get cracking, shall we? Hey, GP learners. So we are going to be getting cracking, having a look at this really detailed document. So just to summarize that, in a couple of weeks ago, NHS England released all the details of what they're expecting for the PCN DES. And part of that is talking about the Impact and Investment Fund. And in this particular episode, we're going to focus on that part of the document. For the DES changes themselves, we'll be focusing in a different way in a more detailed episode that's going to come in a couple of weeks or so. But before we get into that, how are we doing there, Andy?
Yeah, not too bad. It's nice weather. It's sunny and it's a weekend, so I'm doing pretty good. How about yourself, Gandhi?
Yeah, similarly as well. Hopefully the weather holds out, and we're going to have an interesting time looking at this really detailed document, aren't we, Andy?
Yeah, I mean, a few letters have come out, haven't they, in the last sort of few weeks? We've been off the air for a few weeks doing some other interesting things, and a few letters have come out from NHS England, mainly updating on the general primary care network sort of DES requirements, specifications, and then some detailed information about the IAF requirements going through remainder of this year, 21-22, and next year, 22-23 as well. It might be worth just looking at the general letter first of all, and then just sort of diving into the IAF updates. So yeah, 23rd of August, letter to primary care networks and colleagues in general practice. Thank you for your ongoing work. So that's good. It's nice that it's in there and it's mentioned.
There. It's nice after all the recent media stuff as well for NHS England to actually put that down in a document as the first thing is different, shall we say?
Yeah, absolutely. There's a little bit of narrative about things that have been happening through the coronavirus pandemic and some of the successes that have happened in general practice. So they've talked about a fairly successful rollout of the enhanced healthcare in care homes element of the DES, and that people are receiving their reviews, and there's been some success in learning disability reviews. So it's nice, and it's acknowledging the work that's out there. And then they go forwards to talk about the additional funding that is going to be put into primary care network leadership and management. I think that's £43 million in this year, and then further funding for IIF specifications, requirements, and reward for achieving those as part of the primary care network DES as well. And was that 150 million? I think is the figure for that amount. So there is some considerable funding going forwards. And they also make this point, which I think is important for us to stress, that they've decided that additional funding through primary care networks will be through voluntary incentives such as the IIF, and this will be the principal way that they ask us to do more work, recognizing the strain and pressure that we're under, which I think is worth acknowledging, actually. So everything that we're talking about today is voluntary and additional, and is to receive additional funding to everything else that we were previously expecting. What do you think about those points, Gandhi?
I think, okay, so slightly helpful that it does state it's voluntary. This is not mandatory work that the networks have to do, and we're going to explain why that's really important as we get into the document. It's interesting that a lot of this is going to go through the IIF fund in particular. So all the extra funding is there, but basically it sounds like networks are going to have to work for it. That's my interpretation of it.
I think so. Yeah, they'll definitely need to work for it, I think. But I think we'll look at that when we break down the rewards sort of versus how much some of this stuff might take to actually achieve. It's quite interesting to look at that. They talk about the main areas of focus for I think both of these announcements really going forwards, and they're looking at improving prevention and tackling health inequalities. Okay, good. Better patient outcomes in the community through proactive primary care. So that appears to be about case finding for various conditions and attempts to reduce unnecessary hospital admissions, for example, and unnecessary referrals as well. Improving patient access. There's some sections and announcements on that. Better outcomes for patients on medication. So there's a lot of prescribing targets in there as well, and some small number of targets for creating a more sustainable NHS, which I think is nice, and that's perhaps a section that can be built on in the future. And that's essentially what's in the letter. I suppose it just acknowledges that extended access funding will move to flow through primary care networks from April 2022, but I think we knew that already. And then just giving a little bit more detail on some of the IIF funding announcements that we talked about, that were discussed earlier in the letter. I suppose just highlighting that it's £150 million additional money in 21-22 and 225 million additional in 22-23, attached to an increased number of targets and indicators.
And some of you are probably thinking, what were those bits that Andy jumped over? So that was things like personalised care, anticipatory care and stuff. As we mentioned, we're going to cover that when we go through the actual PCN DES letter in our next episode. So not to worry, we're not skipping that, apart from the fact we're going to cover it in a separate episode.
Yeah, there's a lot to do. I think we've got to break this down into 2 or more episodes to really do this justice. So we will be covering Annex A, which talks about changes to the general PCN DES, and a nice table that breaks that down as well, Annex C, but we'll be dealing with that in the future. So shall we just spend some time with the introduction to the IIF guide? So this is Annex B. What did you think in general to the document, Gandhi?
So the document's big. It's not the biggest thing we've ever come across, to be honest. I think it was, what was it, 15 pages, if I remember rightly, Andy?
Yeah. Oh, it's nothing compared to the original PCN DES specification.
Absolutely. However, it's very much information dense. So it is going to take you a bit of time to go through this. I think our tip for looking at this document is, if you will literally want to know the headlines of what's coming, just read the first 5 pages. However, you will then have loads of questions of how do we do this and what does that actually mean, which is what the then subsequent 10 pages try and explain. And for this session, we are going to concentrate on those second lot of 10 pages, because actually that's where the detail and that where the information about what you need to do as practices and networks actually comes from. So we apologize. This is going to get technical at points. Unfortunately, it's the only way to try and understand this document. Me and Andy have been trying for the past hour to figure it out. So yeah.
Yeah, and I don't think even that will be sufficient for everyone to get a full understanding of it. So I think you've got to kind of print out or download to your iPad or your screen, and really have a look at this within your primary care networks as well. But treat this as a guide. You're breaking down that first barrier of picking up the document and being introduced with it with us here.
And just before we get started, absolutely, this is mine and Andy's interpretation of this document. We are by no means experts of this, apart from having read various amounts of these documents in the past. And clearly, if we've made a mistake, we are more than happy to be told about it, particularly NHS England people. If you think we've made an error in this, please let us know. We're happy to try and correct as best as we can. But to be absolute clarity, this is our interpretation of the document. It is not formal guidance, but we'll try our best to give you guys as much help with dealing with this. And we've got some extra resources as well that's going to be coming that will help you understand a lot of this, and has definitely helped us.
So Gandhi, this first bit, I must admit, I found pretty impenetrable, actually, in terms of reading it. I started to read it and then realized that actually it's attempting to summarize the aims and objectives of a complex series of tables that appear later in the document. It keeps referring to the indicators in the tables without explaining them, and actually I find it much more useful to actually just concentrate on the tables of indicators below. But it does give you an overview of what's involved and a little bit of narrative about why they're trying to put these indicators in place. So just as an example, when it's talking about hypertension case finding, it acknowledges that it's a big cause of disease, that there's a lot of undiagnosed hypertension, that will have been worsened by COVID, where people have been seen less and less blood pressures have been done to screen for hypertension, and they're seeking to redress that by putting in place these indicators. So it provides a little bit of narrative like that, but in terms of working out what's actually going on, the tables are really where it's at. I think the main headlines, really, it breaks it down in terms of the sections, really. So there's a section on improving prevention and tackling health inequalities, looking mainly at hypertension, familial hypercholesterolemia. And then there's a section on emergency admission as indicators, and there's a lot of detail in the specifications, to be quite honest. There is a section on supporting improved patient access to primary care services, which is an interesting section.
Definitely stick around for the 22-23 part when we get to that. So yeah, you're going to want to watch this part.
Yeah, and I think actually we're getting into the 22, 23 bits here and delivering better outcomes for patient medications, which are a number of prescribing specifications, essentially, and then a section on helping create a more sustainable NHS. So here are the tables, but first, I think we thought it would be helpful to just back up a little bit and think about, to put all this in context, think about actually how much is an IIF point worth, so that you can look at some of these numbers in context. For example, this first indicator here is worth 36 points, and that has a monetary value for your primary care network. So Gandhi, I think I'm going to hand over to you because this bit is a little bit complicated, and I'm not sure I've entirely got my head around some of these adjustments to work out how much your primary care network will actually receive for their points.
Sure. So nominally, what has been said is that 1 point for the IIF fund equates to £200. Okay, that was what it was like last year, and that's roughly what networks could anticipate getting. Obviously, there's been an increase in the number of points, so therefore, that's important to know. But what they have clarified is the calculation process for understanding what that means, because what they're trying to do is to adjust those points to reflect the differences within each networks. So, for example, if you've got a really big network, having 200 points, £200 per point doesn't really work because that's not fair compared to a smaller network, because there's a massive difference in the types and the way that you're trying to address things with patients. So the calculation, so we would highly recommend that you all have a look at this website. So Health Data Insights, it's created by GP Mike Smith, and we'll put the links in the show notes below, and you can obviously see that we're using this to help us. The website also does loads of other cool things as well. So the lookup tool lets you analyze your network data, so things like number of staff you've got, various other kind of things. But we're not going to look at that right now. And I will put slight proviso that sometimes the data doesn't seem 100% accurate in that part of it. I think it's from a couple of months back. But really useful website. And this explains the prevalence and population adjustments you need to make for the IIF funds. And I don't know if, Andy, you can zoom in a teeny tiny bit on that coloured calculation.
Oh gosh, you might be asking a bit much of me here.
We'll give it a
Chrome, how do we zoom on Chrome? Okay, I think this is how we do it. Yeah, that's about as good as it gets, I think, Andy.
Yeah, so if you just scroll down, and I'm going to make this bigger for everybody else, so it can take me and Andy off screen, so it's as big as it can be for all of you. So the key thing is you've got the payment for the indicator equals the number of points achieved for the indicator, so however many you get out of what it is. So for example, one of the indicators Andy showed you was 36 points, the most you get. If you do everything you're meant to do, you get 36 points. Great, fine. Then you have to times that by the PCN population divided by the national average PCN population. So for the benefits of everybody else, at the moment, that is currently 48,274 is the average PCN population size. Okay. So, for example, my population for my PCN in Nottingham City East is approximately 64,000. So for that calculation, you do 64,000 divided by 48,274. So that's the middle blue section that you can see there. Then for some of the indicators, you then have to times that by the PCN registered size for the indicator. So whatever that number would be, divided by the national average of the PCN registered size for that indicator. That's where it gets really complicated, because I'll be honest, I can't even work out what those figures are. And I think a lot of those figures are based on central databases that we won't have that information straight away. It will come probably later down the road. So that modifying factor changes. Not all the criteria have that one. So, for example, some of them are binary things where it doesn't matter. That's not part of it. But it's important to note that changes things. So Mike's put an example here. Fictional PCN of 70,000 patients for social prescribing PC1 have achieved all their 20 points because they've done more referrals than they needed to do, according to the criteria. And because of the modification you have to make, so they get 20 points times by their PCN population size of 70,000 divided by the national average 48,274. And instead of having £4,000, which is what they would have had if you didn't modify it, they will get £5,800 for that particular indicator. Does that help, Andy?
Yeah, I think I'm pretty much there. I think it highlights how important it is to make sure that your registers are up to date as well, because that's going to be a significant factor in your payment, isn't it?
Yep. So I will be honest, this massively in my head suggests that networks may want to consider actually having a data analyst.
Mm.
Because
So
actually the data is now really becoming important. It's the coding, it's the quality of the data that you've got, and literally just somebody to go through and make sure all the codes are right is gonna potentially create a lot of money, you know?
it is, and they can also work on practices sort of quaff,
Mhm,
quaff work as well. Potentially, there's a lot of overlap with some of these indicators, and a lot of them are designed to complement existing
mhm,
quaff areas, but not duplicate the work. They are asking us to do different things.
mhm.
But yeah, that's really helpful, Gandhi. And I suppose just to highlight how many total IIF points are available. So in 21 to 22, there is 666, auspicious number.
Seriously, NHS England, why did you make it total 6? It's like you're asking for commentary on the fact that there's the devil's number in there and stuff. Seriously.
Well, the devil may be in the detail. But
As
so
always.
that's £133,200, and in 22 to 23 it increases to about 1,000 points, so 999 points, times by £200 per points is, I mean, it's about £200,000, isn't it? Just
Mhm.
slightly shy of £200,000 for your average size network, and that's the total amount that you could achieve if you did everything perfectly, which might be difficult, I think, in some of the areas.
Except when you put it in the calculations for the prevalence and the population size. So it's important to remember that the pot that they've allocated for this stays the same. So I think there is some banking on the fact that networks won't make all the criteria, but there's also an element of remembering that based on your population and prevalence elements, that does change those numbers quite significantly for some networks.
True, you could make more,
Yep.
potentially is how the maths work, because some people
And you could be eligible to
could
only
make
make
less.
less as well. So it's going to be winners and losers, I'm afraid.
Yeah. So shall we look at some of these indicator thresholds and valuation tables for the different areas?
Yep.
I don't think it will make for entertaining podcasting or vlogging if we go through every single one
No.
in detail. So it's probably worth just looking at the sections, how it's structured, and picking out some highlights and talking to things. But I think every primary care network will have to go through an exercise of of looking through this.
And just for clarity, for this particular section, that we're going to be talking about 21, 22. So the remainder of this financial year, these are the criteria that are currently in place. Majority of them kicking off from October, but also clearly you can get started now.
Absolutely. So yeah, how do you want to tackle this, Gandhi? Let's just
So it's
roll
taken in
through.
5 sections, and the first section is improving prevention of tackling health inequalities. So a lot of this is around some of the previous criteria, like learning disabilities, which were from last year's IIF fund, and the vaccinations, if I remember rightly. Is that this one, Andy?
Yeah, the vaccinations were there, and I just highlighted this one just to do some maths on, really, just as we're starting out. So there's
Mhm.
40 points potentially available for a high achievement in patients over 65 years of age who have received a flu vaccine within the kind of flu vaccine season target. So 40,000, that's about £8,000 for a 500,000 patient primary care
50,000.
network, and which is,
Andy, not
sorry,
500. 50,000.
oh yeah, that's, have I times by 20? Oh dear. So how much is it? 50,000.
No. So you said 500,000 patient population.
Oh, that's fine. So the maths, as long as the maths are okay, you made me doubt my maths now.
No, the maths is right. It was the number you said was wrong.
I'm sorry, which is important.
Yeah.
So yeah, about 8,000. So for a 50,000 patient network, and if you take sort of, let's say, there is no typical practice, is there? But a practice of about 10,000 patients, decent sized practice, that's about £1,600 of funding, not for that practice, coming into the PCN for that practice's population's achievement of that. And a lot of this will be done within the practices, of course, which, it's not a huge sum of money, although it does complement, the existing payment for the flu, I guess, and the quaff payments that people would receive as well. But just interesting to note that when you do the maths and break it down to the work done at practice level, whilst the headlines are big sums of money, actually the kind of individual incentives for individual indicators are not that huge, in my opinion, and may not cover the cost of work done in some
It does depend
cases.
on the indicator, I think the other part also to recognise that some of these indicators are put at levels that for some practices simply just going to be unattainable. So if
Yeah.
I was to look at those kind of levels, the upper limit is
86.
86%. Yeah.
Yeah.
Our practice has never achieved 86%, given the deprivation and the local issues that we've got in terms of convincing and suggesting to our patients that they need to have their flu jabs. You know, that's not something our practice is going to be able to achieve. It's a theme that runs through our entire network. The reality is we recognise our network is probably not going to achieve this criteria.
Yeah. Just throwing something out there that we'd noted down for comments at the end, but is there a danger that actually some of these thresholds will exacerbate the inequalities of funding for primary care networks with difficult to reach populations? We might talk more about that later, but I'm just sort of putting that out there here as a risk, I think. So there's indicators based around flu, essentially, and then we move on to the CVD indicators, which is really looking at finding and following up people with elevated blood pressure, essentially, and incentivizing that. So,
important to note, this is a new indicator for this financial year. So it's an additional piece of work. And as far as we can understand, this is meant to, as NHS England have written in the document, complement the work that you're already doing in practice when it comes to QOF. So we are taking this to be that this is not going to replace the QOF payments for cardiovascular disease. We hope that's the case, and that's our interpretation of it.
They haven't said anywhere it's replacing it, so hopefully not.
And like you said, Andy, this is to try and improve the prick-up and prevalence rates of hypertension across network areas. And clearly, this is somewhere where things like working with your local pharmacies or other kind of healthcare environments may be really useful to try and pick up your numbers and look at tackling hypertension in your network area and stuff. But it's interesting stuff.
It is, yeah. So it's looking at acquiring new readings above 140/90 and giving them appropriate follow-up. It's fair. And
the combination of those two things is that's coming up to 80 points, which is a fair amount of funding potentially.
Yeah, well, it's going to be about £16,000, which is going to be about 3,200 for a 10,000 patient practice. So they're not insignificant amounts, and I think a lot of this hinges on how achievable some of these numbers are, and it's difficult for me to conceptualize that really. So the threshold here is 20%, 25%. So Gandhi, is that of the total population? Help me out here.
So it's different based on each different criteria.
It is.
I've forgotten what it was for this one.
It's really tough to get your head around.
It is, yeah. I think we'll come back to figuring some of this out with some of the other bits, shall we?
We will, yeah. But let's have a look. So, so percentage of registration on the hypertension register as well. So I think it's looking at getting us. I think that's a general indicator of how much of the hypertension out there you have identified relative to what would be expected. So I think that's looking at the size of your hypertension register relative to what would be expected. Another way of incentivizing case finding. So that's helpful. So should we move on to the next section? Supporting better outcomes. Supporting better outcomes in the community through proactive primary care. So I'm finding these a little bit more easy to get my head around, actually, how they actually work. So we're looking at percentage of registered patients referred to social prescribers. So we're used to this target. That's an existing target that's carried through from the last year. And then there are a number of targets looking at beginning to quality assure some of the work that we have been asked to do as part of the main primary care network, DES, but have sort of just so far, I think, received payments based on assumptions or self-declarations that work is being done, and this ties some additional funding to kind of quality assuring that a lot of what is expected is happening. Is that your interpretation?
Yeah. So I think this particular area, like you say, formalizes a lot of the information that was given in the previous IAF criteria. The main one, I think, that's properly formalized is that last one, EHCH04. So the average number of patients reviewed on a weekly basis from a care home. So lower target is 3, upper target is 4. So to get those points, 13 points, a few £100 per practice, basically. You need to be reviewing at least 4 patients per ward, per care home per week.
Which I think should be happening, shouldn't it? So I think this section is reasonable, really, because I think in most primary care networks this activity will be happening.
And one thing I haven't seen is that they're saying they're removing the £120 per care home bed for the enhanced service either. I can't find anywhere where it says that they're removing that, so that will be in addition to that particular element of funding.
Yeah, which is good. And then there's a few elements in the middle, isn't there? Was age over 18, personalised care and support plan. I'm not sure I've seen have they specified what that should look like anywhere, Gandhi? No. So maybe it's for networks or groups of networks to decide what that would look like. People correct us if we're wrong. And then obviously people receiving a structured medication review, and that hasn't been specified previously. I think that's been linked previously to the capacity that your care home, that your primary care network has in terms of how many clinical pharmacists you've been able to recruit. But now they're putting numbers and targets on that.
Yep. So next topic is then looking at the support improved patient access to primary care services. So a couple of new criteria that come into this. So the first one that many people probably remember that we talked about back in April was about mapping your appointments. But now they've added in about online consultations per registered population. And then also discussing the implications of A&E attendance and stuff. So I'm going to pick apart this particular one, ACCO2, the online consultations one. So the criteria for this is you have to offer 5 per 1,000 per week of your registered population size. So 10,000 patient practice, you have to offer 500. Oh gosh, my maths has gone now.
50.
What's going on? Yeah, 50 appointments per week per practice. Okay. So for some practices, given the changes that have happened in general practice, this will not be an issue. If your practice that predominantly uses online consultations as your main route into practice, to be honest, this should not be a problem whatsoever. If you're a practice that does not use online consultations as your main route into your practice demand, then potentially this is going to be a significant challenge, I think, for some practices. And, the amount of time and effort it's going to take. So let's go with a typical population size, 50,000 PCN. Yeah, that's 250 consultations per week they have to provide. That's 50 consultations a day. Yeah, 5 working days. That's, depending on how well those GPs are working, that's 2 or 3 GP sessions per day to deal with that particular workload. Given the fact that an average session goes for about £300, shall we say, 3 sessions, that's just shy of £250,000 of cost of workforce load that is needed in order to manage those online consultations. The potential reward for that is £5,400.
Yeah, it doesn't stack up, does it? I think this is one to leave on the table if you're not using an electronic consultation system somewhere within the primary care, network.
Yeah, as you said, Andy, if you're a practice that has online consultations as your main route of contact for your network, then this is basically a nice little tiny top up that you're going to get. If you're a network that doesn't use online consultations predominantly, then this is potential additional funding, but additional funding that you may want to evaluate whether or not it's going to be effective for your network to go for based on your population adjustments and stuff. And this is, I think, something we're going to see with quite a few of these criteria and the indicators. I think networks will need to evaluate whether or not the effort it's going to take to reach these criteria is actually worth the potential reward that you will get for them.
Yeah. I think an exercise to sit down with volunteers or all the practices and actually just decide what's achievable, and cross some of this stuff off with a red pen is probably going to be occurring up and down the country, I think. This one I think is, it's a nice incentive to perhaps adopt one of those systems, although compared to the cost of adopting one of those systems, it's also pretty insignificant. I mean, they cost a lot more than that to deliver that volume of, to cover that many thousands of patients costs a lot more than that. So if they're really serious about this, then maybe they could incentivize it better, I think. And of course, the thresholds and the rewards can change, can't they, year on year? So they might dial this up a few notches in the future. If it's there, they can always change it. Yeah, the next one is really, I think it's just like it's a single discussion and make a plan around the implications of A&E attendances for minor conditions. So that's a kind of have that and make a plan one, which I think is good.
The criteria of what that means is not detailed as well. So, is that similar to, I guess, the QoF QIA work where we got together as practice and had a discussion about how to change things? Would that suffice or not? That there's no unfortunate criteria put in as to what that document or discussion needs to look like and who needs to be at the table as well. So concerned that, and it's a binary indicator. You've either done it or you haven't. So who's assessing whether you've done it or not?
Well, probably the local CCGs. They tend to sometimes apply their own criteria to the achievement of these.
Document comes into play,
which can be anything from clinical director self-declare that this has occurred to provide actually some complex reporting on this issue. So we'll see. It's 56 points, so it's quite a lot of money actually. Compared to some of the indicators. And then we need to work collaboratively with local community pharmacy colleagues to develop and commence delivery of a plan to increase referrals to community pharmacy. So we've already started some of that work in our area, haven't we? So, so it's just a case of continuing that for us. But obviously, the powers that be consider this important, and it's a good way of actually decreasing pressure on general practice, isn't it? To use our community pharmacists to assess what they're able to assess in the community. So I think that's fair dues. And then there's this again, another binary sort of exercise to look at GP patient survey results. So we did a video on the GP patient survey, didn't we?
Yep, we did
recently.
And you're more than welcome to check it out. We'll put that up at the end of this episode so you can have a look at that, so you can see our perspective on it. I think it's interesting to look. This part says about having a discussion about the inequalities and the experience of access to general practice for particular patient groups and developing a plan to improve access for those patient groups. I think what'll be interesting is that every practice will have different patient groups potentially, and how do you manage that? My suggestion for, I think, networks for this particular criteria, along with the other ones, is try and combine all those meetings in one meeting, so you've got it all done in one go. And hopefully that will allow you to come up with plans to figure out how to tackle this and potentially give you in line for some additional resources to help with this. This is completely different to the criteria for 22-23. This is the part you're going to want to stick around for,
which we'll get to later. And then there's this area of to create a more sustainable NHS, which is around moderating the use of metered dose inhalers, which is work that we're used to already doing and being engaged in. And then so 2. Mean carbon emission per salbutamol inhaler prescribed on or after. So this indicator is in kilograms. This one sort of foxes me. So is it kilograms of CO2?
I'm assuming.
I just found this one.
This is one the way you need to have a discussion with your local medicines management teams or your network pharmacists and figure out what it is you're trying to do and how to do it, because we'll be clear, we cannot advise you on this part, because I have no idea that the carbon dioxide amounts for individual inhalers and how that looks. My concern with this particular one is supply is going to be a mitigating factor with this. We know that supplies of medications is constantly changing. Supplies of inhalers in particular may massively change. So whilst we may try to tackle this by adjusting patients to more sensible and appropriate inhaler treatments, if the supply of these inhalers suddenly goes whappy because of all the other supply issues we're currently having, then it's almost like a fail complete. You're not going to get it.
Yeah, absolutely. And obviously the different inhalers will have different carbon footprints. So this is obviously incentivizing us to use the inhalers with lower carbon footprints. I just thought it was interesting that it's expressed in kilograms. I don't think any of the other ones are. So we're moving now into the 22-23 and onward additional indicators here, and there's a lot of them actually. So I'm just, were there any you wanted to focus on before we skip to the one?
So they carry on basically almost all the ones
similar
we talk about. However, some of the criteria are further enhanced. So particularly the vaccination ones are further enhanced. The cardiovascular ones are further enhanced, as you've highlighted there.
Yeah.
And I think there's an extra couple of cardiovascular ones as well, isn't there, if I remember rightly? Yeah, there's another one,
Yeah.
CAVO3 and CVO4. So looking at patients with cholesterol levels checked and Q-risk scores checked. So they're basically enhancing it,
Yeah.
expanding it, whatever you want to call it, and things. So important to recognise that it gets bigger, and that's why there's more points available in the following financial year. I mean, that's self-explanatory, basically.
Yeah, that's it. I think people just need to spend time with it and maybe, concentrate on 22, 20, 21, 22 now, but just have an awareness of what's coming in the future, so you know that you can kind of ramp up your plans, really.
And then
other areas enhanced.
Yeah, so this is again further formalized, so some of the criteria further adjusted, but then they've added in some extra ones. So EHCH4 and ACO2 are really interesting. Do you want to go through those, Andy?
Hang on, direct me again to the
Oh no, sorry. EHCH06.
Yeah, so they're beginning to ask us to do work on reducing admissions here, which has always been a really, really tough nut to crack in the past. And I just think it's interesting moving into that area. There are lots of factors, not all of them within primary care networks, direct control that affect admissions to from care homes. And I just think it's an interesting area to move into. 27 points, so it's not actually a great amount of points, and it's paid in terms of achieving an improvement, essentially. I just think it's an interesting area to move into. Similarly, ACO2 is about the number of emergency admissions for specified ambulatory care sensitive conditions, and we'll have to go down to 0.8, or people will if they just want to see which conditions are included in that. But these have always been really, really difficult things to achieve in the past. This ACO2 is one of the more valuable indicators in the specification, with 111 points, which is about £22,000 for the average primary care network, or about £4,440 for a kind of 10,000 patient practice or attached to their population achieving this indicator. So it's quite a lot of money, but given the scale of the problem, maybe it isn't a lot of money. Although I'm not quite sure how to interpret this reduction thresholds here, in terms of thinking about how achievable that would be.
I think things that are relevant to this. So there's two different criteria. So it's a reduction either in percentage or absolute numbers. What will be interesting is I can't find any details in the document to state which one is the priority. So, for example, if you achieve a reduction based on absolute numbers but not on percentages, does that mean you get paid or not? Is that valid or not? It doesn't specify. And if it does, apologies, but I can't find it. So it's not obvious to find. Secondly, you kind of need to know what your benchmarking information is now in order to figure out where you're going with this. And I think that's one of the complicated parts with this as well. Where do you get that information from? Because it says it's taking it from 2-3 different sources as well. So which source do you use, and how do we specifically access it? This is going to require system level engagement, which is partly what the PCNs are meant to do. But this is going to be a really big discussion with other providers as well, because this is not general practice's responsibility to fix. Whilst we're part of the solution, we can't fix these issues on our own. So in terms of reducing admissions to A&E departments, some of the later ones it then talks about is standardization of referrals as well. So these things require massive amounts of engagement with system players.
That's later. Sorry.
Yeah, this is complicated, and it gets even more so as we move into section 3. So should we head down to that?
Let's go there. So for the first time ever, I think there'll be some payment attached to how patients report their experience of the practice, and in particular how they report their experience of the ease of getting a consultation. So we're looking at the proportion of people who say it was easy or very easy for them to make a general practice appointment. And the target here is 66th percentile of performance from piloting, which is a bit opaque to me. Do you know what that means, Gandhi?
No idea.
No, I'm not sure either. But this is an area where we struggle as a practice, actually, and we try really, really hard to make sure that the phones are picked up and that we have a lot of people picking up phones at heavy times of the day, and that we make appointments available, and we try and and we make appointments available online, and we try and make it very easy. But still, people are dissatisfied, and I think the general mood is that many people are dissatisfied. So this one feels like it might be a difficult one to crack.
And I think one of the things that frustrates me about this is it uses the word appointment. It doesn't specify what type of appointment. So does that mean face-to-face? Does that mean telephone appointment? Does that mean online consultation? Does that mean video appointment? Does that mean group consultations? It doesn't specify the type of appointment, and most people interpret that as seeing their GP, which actually we're then being asked to change the way that we deliver general practice to provide more resources. That question, when you've got, we looked at this when we went through our review of the survey, the questions are opaque in terms of what they're asking patients. Their interpretation of that very much, I think, will mean that this particular section is designed not to be paid to majority of practices.
Although they're linking it to percentile of performance from piloting. So that, I wonder if that's at least an attempt to kind of standardize for the difference in interpretation and so forth. I think we just have to see how this plans out, but it's 111 points. That's one of the biggest. That's the heavyweight indicators are 111 points. So I don't think there are any
over 10% of the funding is based on how well your practice evaluates on the GP survey in terms of ease for patient booking an appointment.
Yeah, so it's a real elevation of the use of the GP patient survey, actually, because really it's been formative, really, until this point. We've reflected on it and responded in a sort of formative thing, but it's sort of performance management. It's quantitative now from the GP survey.
Interesting to note that ACO2, the one for online consultations, which for this year they said was 5 per 1,000, to be confirmed how many it's going to be. So they're not prepared to tell us what they're thinking in terms of whether that's meant to be more or less. I suspect it will probably be more as usual. But then at the same time, politically, we're being told that we shouldn't be offering remote first. We should be offering now face-to-face first, because that's what Sajid Javid and various other people want, because it's politically nice to say so.
I think it's fair to keep that an open question, actually. I don't think we've fully evaluated and reflected on our kind of venture over the COVID times into telephone and online appointments. So I'm not sure we know what the right amount is yet. So they're keeping their options open. And then what we call advice and guidance in Nottingham letters. So the facility to ask a speciality a question before doing a referral. ACC07 seems to be encouraging us to do probably more of it. We're probably not doing as much as they're asking in terms of the thresholds. Yeah, they're gonna pay for between, so this is per 100 outpatient first attendances. Payments start at 6.6 and end at 19. So really up to 20% of appointments, the expectation might be that they have an advice and guidance first or instead of, I guess.
And that's covering 12 different specialities. So cardiology, dermatology, gastroenterology, gynecology, neurology, urology, pediatrics, endocrinology, hematology, rheumatology, respiratory, and ENT. Again, this is going to require system change. This is going to require discussions with your hospital providers, your ICP levels, your ICS, to get those kind of, to hit that is only going to work in areas where you've got those open discussions. So if you don't have them, you need to start making them now. Otherwise, this funding is, to be honest, not going to happen for your particular network.
Yeah, I think it's with all those specialities having a heads up that they're going to get more of these A&Gs. And I think as it stands, we can send them and they're contractually obliged to accept and respond. But they're perhaps going to have to restructure their services if the amount of these queries coming through change. Percentage of patients.
Yeah, this is a fun one. And I think this is going to hit the GP headlines. I'm surprised it hasn't hit it in more detail. But percentage of patients who had to wait 2 weeks or less for a general practice appointment. So all the comments we made earlier about the type of appointment, not categorized in this. So I would argue that an appointment is an online consultation. Therefore, most practices could easily argue that there is no wait at all because you can submit an online consultation, therefore that counts.
Yeah.
I think the criteria looks at routine GP appointments and what that means, but it doesn't specify whether that's face-to-face or telephone. And I think when they clarify whether that counts or not, that's going to be a key part of this.
Or how it's measured. There are.
Mhm.
I'm just thinking how you actually measure this
So it's measured based
accurately.
on the GP standardization of appointments work that the practice has been doing. It comes
Ah,
lower down in the document. It does
right.
specify which ones are clarified, and it is those appointments that are considered routine general practice, not the urgent general practice one. So we'll come to that a bit later on.
Okay.
But as I said, I don't think it clarifies the route. So I think for many people, this is potentially achievable unless they come out and clarify that route has to be face to face, in which
Mm.
case it's massively going to change general practice.
And then referrals into the community pharmacy consultation service. So we need to talk to our community pharmacists and make sure
Yep.
there's a good, and they probably need to be supported to make sure that there is a good service in place. A lot of demand on good clinical pharmacists. They're coming into primary care networks, but they also need to be working in the community as well. Deliver better outcomes for patients on medications. There are a lot of measures in here coming in 22, 23, looking at prescribing safety. Is this? I mean, there's quite a few. Is there any that you want to look at in detail, or is this one to kind of pick apart with your pharmacy teams?
So to be honest, this is a section I would just simply go to either your network pharmacist or go to your medicine management team and say, we need to do this. How do we do it? And there's two reasons for doing that. Number one, this is predominantly a pharmacist level workload because it's looking at reports and also putting systems in place to make sure prescribing is safe. That is what our pharmacists are designed to do. Secondly, in actual fact, the number of points this is really low, even though it sounds like a lot of work and there's loads of different indicators for this, and they're all slightly different. So they're about prescribing, either reducing the prescribing of NSAIDs or anticoagulants, particularly in inappropriate use, or when you have to use them, making sure you prescribe PPI to protect the GI tract. And it's different depending on age groups and stuff like that. But I think in total, it's about, for all the criteria, it's something like 20 points in total if you rack it up. So
yeah, it's I'm just looking at some of the later ones.
the later ones are a bit more. The asthma ones are interesting because we couldn't make head and tails out of the asthma ones, to be honest. So yeah, that one, RFSPO1, percentage of patients on cough asthma register, okay, that's sensible, who are regularly prescribed an inhaled corticosteroid over the previous 12 months. And then it says 3 or more prescriptions or 4 or more. So I'm assuming you're looking at compliance of ICS medication in patients with asthma. I think that's what it means.
Yeah, I'm not quite sure. Not quite sure what
It's not clear,
they're
unfortunately.
driving at.
So NHS England, please, could you clarify what exactly that means? My interpretation of that is that for 22-23, they want to make sure that you have prescribed 3 or more ICS prescriptions in a calendar year in the previous 12 months for patients with asthma. Because we know that generally patients focusing more on their ICS medication rather than on their reliever medication is better outcomes in terms of health outcomes for asthma. So I think that's what it means.
Yeah, so they want to make sure people are
types of inhalers, because then that doesn't make sense in terms of clinical guidance, because you wouldn't really have an asthma patient taking 3 different ICS inhalers, which is, I guess, take that information.
Yeah, I'm not sure, because surely people, if they're compliant, they should be having more than that. But anyway,
well, they should be. I think that's what it's trying to focus on.
I know.
We know in the past that many patients seem to focus predominantly on their reliever medication rather than their maintenance medication, and actually we know that from outcomes point of view, that's not ideal unless your asthma is not that severe. If your asthma is severe, then you should be ideally be on a steroid inhaler.
But whether things are prescribed is not a great indicator of compliance, and whether they're collected from the pharmacy is not a great indicator of compliance either.
But anyway, I'm assuming that's something they think they can quantify us against, therefore that's what they're doing. And then the final one is further details in terms of the MDI and inhaler type carbon emissions and stuff, and the criteria are further enhanced. Which again, this is an area I think this is where your network pharmacists will definitely be getting their workload from.
Yeah, further reductions in average CO2 impact of inhalers.
Absolutely.
Yeah. So interesting. So that's essentially the end of the
Yeah, that
period.
table there
Really.
goes through the appointment types that we talked about just
Yep.
now.
Yep.
So, and some of them can be exception reports and some of them can't. So you know, you can exception report for general consultation routines, but not for acute ones and stuff. And this is based around the appointment data workload and stuff that's hopefully already been done by most networks. But then trying to evaluate it based on, I think, and I suspect what they're planning to evaluate is on further criteria for next year and things with.
Yeah. So this is about ACCO 8, isn't it? And working out that 2-week wait, which I must admit we've not calculated and sort of puzzled this out. So people are welcome to do that. Well, Caroline Moises just asking if this is recorded. It is, and you can watch it again on YouTube.
Yep. And I suspect you probably will want to go back and read and rewatch sections of this because it is complicated. We did give you that proviso at the start, and again the disclaimer that this is our interpretation of the data. We tried our best to make head and the tails out of it, but both Andy and I have spent at least an hour each going over this document, and this is what we've come up with after spending that amount of time. So yeah, what are you thinking there, Andy? Then.
Yeah, so right, I think we've had a nice introduction to the document this morning, and I think everyone watching and ourselves will have to go away and look at this in more detail with our teams and colleagues. Yeah, I've got a few thoughts really. So I think some of these criteria are tough. I think some of these criteria are tough to achieve when you get down to it. You know, you really need to sort of look at how much funding is going to come in for how much work you're going to have to do, because you can't do everything. And you know, everything in this document is not the entirety of general practice. You know, people still need to be seen for bread and butter general practice, and you know, and that's what most patients care most about, I think. So I think primary care networks and practices will go through an exercise and have a look at what they think is achievable, and you know, some things might have a red pen through them. It's nice that it's, you know, it's additional money, isn't it? Oh, I do think often, you see, that sounds nice, doesn't it? This is, you know, we're not requiring you to do additional work, but we're putting additional money on the table for doing noble, good work. But actually, in many cases, the amount of money might not actually cover the work that's needed to be done. So you might have to not do it. And I just wonder if this is interesting positioning on some of these issues for NHS England and the government. This is, I'm getting my tinfoil conspiracy hat out a little bit here, but you know, if you offer the money to do things which are good to do and noble, and then those things don't get done and those improvements don't get made, then the government and the powers that be can say, well, oh, you know, we put money on the table for GPs to do these things, to improve access and improve pickup of cardiovascular disease and so forth. But actually they didn't achieve, you know, these things, and you know, therefore, you know, they didn't receive the conditional payment, but we're encouraging them to do it. You know, it's their fault, essentially. So I'm sure NHS England and the government wouldn't do something like that, but I just wonder, it's just interesting positioning and potential, you know, tactics on some of these issues. I've become increasingly cynical as I go through my career and sort of look out for these stitch ups. Yeah, I've got a few more comments, but what's your initial thoughts, Gandhi?
Just before I give them, if any one of our viewers that are watching us live do have any questions they wanted to ask us, like Caroline did, feel free to do so. I'm more than happy that we can try and answer any questions and stuff in this particular section. But I think, like you said, Andy, I'm slightly, unfortunately, cynical about this. And okay, most of AGP listeners know I tend to be a little bit cynical when it comes to some of this stuff anyway. But like you said, I think you know, a lot of the criteria are set up in some ways that are really challenging for certain networks, and particularly those networks where health inequalities are a real challenge. I think they will struggle with some of these parts quite considerably. You know, you look at the funding for, you know, GP contacts within 2 weeks, for example. All the funding we've had when it comes to network stuff is to increase the access to other roles, not to GPs. You know, so there's funding for pharmacists, for PAs, for all those kind of things. And now they're bringing criteria that focuses on being able to see a GP. Now, I know the counter argument to that, but we've provided you funding to produce all these other roles, so that should free up your GPs. So then they could see more patients, and therefore that's why the access to GPs should be better. However, over that time, we know that we've had a considerable reduction in the number of GPs working. The workload has exponentially increased to the point where it's really more challenging. And actually, we are now being taken out of practice to supervise all these other roles as well. So our availability is actually going down and down and down. So that argument I would actually more happy than counter and stuff. So I think then putting criteria that says about seeing a GP um, and the loose wording of it is, to be honest, a little bit insulting at times. Um, I think what I would recommend to a lot of networks is look at these criteria, look at these indicators, and look at the ones that you are likely to realistically achieve. And that's not to say you don't try and achieve things that you think are a bit challenging, because absolutely that's important. And hopefully that increased resources and stuff will allow your network to provide more services to your patients. But also not to chase stuff that you just, to be honest, to do so is going to be so difficult that you're going to burn yourselves and your practices and your teams out trying to achieve them. Because as you said, I don't think a lot of these things are worth the funding that they're offering, and they are being offered with a view of saying, "We've offered funding and they didn't do it."
Potentially, allegedly. But
My
yeah,
interpretation of it. So, yeah, not allegedly, that's my interpretation of it. I'm happy to stand by that because I do see some of these criteria being exceptionally difficult for some networks to achieve and seem in some way to be designed in that way.
yeah,
But
yeah. Bad news for health inequalities, I think.
yeah.
And not really doing much to tackle those. To be honest, we've got
I mean,
an
this does
indicator
nothing
level.
to tackle those patients with challenges with language difficulties, for example. This does nothing to tackle the, ethnic variations that you have and those aspects of difficulties with practice. This does nothing to help those inner city practices that have those challenges in terms of how they fund and structure their practices. It does nothing to do with estates, which is actually one of the biggest limiting factors for most networks and practices in terms of delivering all of this care. There's no information of that whatsoever and how that's going to be
You could
tackled.
spend the money on estates, Candy.
Yeah, so you're right on that point, and thank you for reminding me. So one of the main positive things have seen about the IF fund is you can pretty much spend it on what you need to in order to make your network more viable. So unlike most of the other pots of money, which come with really stringent requirements what you can and can't spend the funds on, this one is pretty much, as long as it is designed to help improve the network's delivery of services, and that's a pretty loose term to be honest.
As long as it's additional, that seems to be the only thing. You
Yeah,
can't pay twice for things that you're already
yeah.
doing, which obviously would be wrong.
But for example, this is one of the only pots of money where you could actually pay for more GPs if you wanted to.
Mm.
You could actually pay for more nurses,
Absolutely,
which is
Gandhi.
shocking that none of the other funds allow you to do that.
I was going to say, just talking about recruitment, wouldn't it be nice to know where NHS England's priorities are in terms of what they're going to reward primary care networks to do before primary care networks produce recruitment plans and
Yep.
workforce plans and submit them? I'm just aware we've just had a few deadlines to submit workforce plans for this year, definitely, and provisional plans for years going forwards. And I'm sort of left there thinking, well, maybe some of those primary care networks that might have felt that they were responding to real community needs for health and wellbeing coaches to tackle problems like obesity and inactivity and some of those things that are not covered in these criteria, might have rather have spent that money on community pharmacists, for example, to help them achieve some of this additional funding. It would be nice to have had these things earlier, I guess, so that we could shape the workforce to actually meet the task that we're being asked to do.
I completely agree with you there, Andy. If you look at the IF fund to achieve this, the key roles that you need in order to manage that is the clinical pharmacist. That creates and allows you to tackle majority of the stuff that's going on in the IF fund. And do you then this funding basically suggests you focus as much as you can on that to deliver that part of the workload, and maybe at the expense of other roles, because actually then that's likely to have you more net benefits in terms of how you work. But then actually in terms of the face-to-face kind of on the ground impact in practices, I still maintain that actually, like you said, the roles like the health and wellbeing coaches and the PAs and the physiotherapists are more likely to help with patient experience in terms of what's going on in the practice, if you can show the patients that actually those roles can give them benefits rather than seeing a GP for everything.
Hmm. Okay, so it feels like we're welcoming that it's new, additional money. We're a little
Mhm.
bit questioning of the tactics behind doing it. Some of the work is tough. It sounds like we feel getting in some people with the right expertise, like a data manager, might be a really good
Mm.
idea
Yep.
for a primary care network to do, or at least a really, really good practice manager who's used to managing to targets and doing some of that data work, a practice or a network manager.
Mhm.
I think a lot of this is similar to the QOF work that practices do. So if you can really get your practices on board and
Yeah.
their data teams, coding teams, their clinical teams to kind of adopt some of this work alongside the QOF work, I think that that would be a really good tactic, because practices do have approaches and systems in place for their QOF that they can maybe piggyback some of this stuff on, but that does require getting them really on board with it. And I think you're going to have to show them the benefits to them
Mm.
of getting on board in terms of what they will get to help them do it, and help make their lives and the lives of their patients a bit better. But it's new additional money, so maybe we shouldn't be quite as cynical as we are being.
Fair enough. And we will find out, I guess. That's the key thing. So, this is a document that outlines the funding for this and next financial year. I suspect there'll be adjustments made throughout the year, and if not next year, in terms of what this looks like. I'm really keen to know what other networks think about this. We've given our perspective, as you mentioned. Love to know what other people think. So if that's the case, please let us know down below in the comments. Obviously, contact myself and Andy, whichever particular platform you want to do. Our contact details are underneath and stuff as usual and things. And as ever, we're here to give you more information and stuff. If you do want to check out some of the other videos we mentioned, they're coming up right here, probably in a few seconds or so. And as always, we're here to help tech enhance your primary care and learning. And we'll catch you in the next episode.